Really, our next speaker needs no introduction. Since Dr. Child retired, the former director of the program, really Dr. Shannon is now the senior medical practitioner at the ACHD program by virtue of him being the oldest. He's known as the Big Kahuna. He is I've got to just say, Dr. Shannon is a world-class congenital electrophysiologist. He, I think, is one of the smartest doctors in the hospital. If there's something that I can't figure out, this is the guy I go to for help. So without further ado, Dr. Shannon will speak to us about arrhythmia management in single ventricles.
Just for the record, that's the first time I've been called senior. So I'm going to talk about arrhythmias in single ventricles. It's kind of a pretty brief topic. It should be no problem to cover this in 15 minutes. If I talk fast, that's Jamil's fault for giving me 15 minutes to talk about this. I'm sad to say I have no disclosures. So when we talk about the arrhythmia in single ventricles, really not talking about the natural history, because there is not much known about the natural history of single ventricles. Mortality without intervention is extremely high in the first year of life, and so we almost never see unpalliated single ventricles. We do, but it's relatively uncommon. So what we're really talking about is what is the unnatural history, aka what are arrhythmia considerations in Fontan patients. And there's obviously three kinds of arrhythmia: atrial arrhythmias, atrial tachyarrhythmias, bradyarrhythmias, and then ventricular arrhythmias associated with, or not associated with, sudden death. What I'm going to talk about is what is the scope of the problem, what are the risk factors, and then what are the interventions for this? How do we manage this? And I'm going to quote several papers that are in the syllabus or that are relatively recent reviews of this. This one is from Congenital Heart Disease in 2016. Sudden death and late arrhythmias after the Fontan operation, and they looked at a very large number of Fontan operations, over 1,000 in the start of this study, and then 800 some odd after the initial stages. And in this 30-year follow-up, you can see that this is arrhythmia-free survival. The thing that shocked me here is that 30 years, 25% of patients have not had arrhythmia yet. I find that number suspect. When I see a Fontan patient, I pretty much tell them by 30 years, everyone has had some kind of arrhythmia. Apparently, I'm wrong about that. It's only 75% of them. And then these are the kinds of arrhythmias that they have. Atrial flutter, the overwhelming largest number. Atrial fibrillation is not uncommon, sadly. Ectopic atrial tachycardia, reentrant SVT from congenital anomalies like accessory pathways or twin AV nodes. And then ventricular tachycardia accounts for about 5% of arrhythmias. Not up here is sudden death. 5% of Fontan patients experience sudden death in this study, which is similar to tetralogy of Fallot. I don't think it's a small consideration in this population. So I'm going to talk a little bit about that later. And then this is freedom from arrhythmia by type of Fontan. These are the aortopulmonary connections. We know that those didn't do particularly well. These are the lateral tunnels and other, I think that may be Bjork modifications, didn't really say. And then this is the extracardiac conduit. This is only 10-year follow-up. The extracardiac conduits were a small number, only about 40 in that group. And these were not statistically significantly different, even though they look like they diverge quite a bit, but there's a bigger study I'm going to talk about. But clearly these two are better than the atriopulmonary Fontans, which is not surprising. And then in this study, comparing intracardiac lateral tunnel and the extracardiac conduit Fontan, this is a multi-centered study published by Dr. Balaji. This is also a recent study. And here you can see that this is for bradycardia, time to first pacemaker implant. Surprisingly, they were similar. Out here, the extracardiac conduit had a slight advantage, but early on, it had a disadvantage. There were more patients who needed pacemakers for the extracardiac conduit. Not really clear why that is, but in our experience, that Gore-Tex conduit lies against the right atrium or the atrial tissue, whatever it is, and we see scarring when we go back and do mapping and ablation in these patients, and we see a scar that runs right along that conduit. And it's not from an incision, it's from irritation of the atrial tissue from that conduit. So if that conduit happens to sit near the sinus node, you can imagine that it would irritate the sinus node and maybe the sinus node would stop working. So that's something that we can probably improve on. This is same patient population, freedom from tachyarrhythmia or time to first tachyarrhythmia, and there really is no significant difference between the two. So the extracardiac conduit in terms of arrhythmia is not all that wonderful in preventing tachyarrhythmias or even bradycardia. It may have an advantage in maintaining hemodynamics because it can't dilate, and very long term it may have an advantage, but thus far we haven't seen that. So what are the treatments for these problems? Well, obviously for bradycardia the treatment is a pacemaker. The real challenge there is in some patients we can do transvenous pacemakers. Is that worthwhile to avoid the thoracotomy, particularly in patients who may need a future transplant? We have been doing that a fair amount in the high-risk patients for thoracotomy. Our go-to is still epicardial, but I think as we get more experience with that, it may be a viable way to put in pacemakers in these patients and avoid repeated thoracotomies, which we know can lead to problems when they need surgery or transplant. For atrial arrhythmias, ablation, more ablation, and more ablation. I think a non-pharmacologic approach is much better than a pharmacologic approach. Anybody who talks to these patients on antiarrhythmics suck. Nobody likes taking them, particularly beta blockers, and anybody that is young who takes a beta blocker notices the change in their ability to do things and they don't like it, particularly if they don't already have a pacemaker. And so I think that aggressive approaches to ablation are probably warranted, particularly now that our success rates are reaching fairly good numbers, which I'll talk about. Obviously, most of these patients wind up on medication, but we do try and avoid that. And then for sudden death, obviously, the treatment is an ICD, and I'm going to talk a little bit about how you can do that in the modern era. For ablation, as I mentioned, best done early and often. One of the biggest challenges to doing ablations is you have a patient who had their first arrhythmia 15 years ago, got treated with medication, started breaking through that medication, got a different medication, broke through that. Now 10 years later from their first arrhythmia, we go to do an ablation, and they have 7 different forms of atrial tachyarrhythmia, and they jump from one to the other. And doing an ablation is a lot like going hunting. In order to accomplish your goal, you have to see the game that you're going after. You can't kill something you can't see. And if you keep seeing one deer and then a boar and then an elephant, you're not going to catch anything. And if you chase one, then the other, you're just going to chase yourself in circles. And so, it's better to do this early when we only have one arrhythmia, something you can target easily. And so early and often is my preference for ablation. So we recently published our experience, or a multi-center experience in ablation for external cardiac conduit Fontans, which is probably the most recent up-to-date experience. In that study, which had 9 centers, there were 46 procedures. 38 of the 46 were acutely successful. Medium term, which is really only about 4 to 6 months, was 70% successful. I usually tell people when I see them, I consider this a success if you are substantially improved 1 year later. And substantially improved means that you either are not having arrhythmias on medication you were on before, or you're off medication and not having arrhythmias. That is my definition of substantially improved. It's not that you're tolerating arrhythmia better because you now know how awful an ablation is. But we do get substantial improvement, either control with antiarrhythmics or control off antiarrhythmics in about 70% of patients at 1 year. Just to give you an idea of what this looks like. So this is the various approaches to get to the atrial tissue in the extracardiac conduit Fontans. So you can either do a transeptal from below through native tissue that's adjacent to the atrial tissue. And in the patients who had their extracardiac conduits at a younger age and grew some, there's actually a significant amount of tissue here that you can go through that's not conduit. You can go through the conduit. Sometimes that gets very scary looking as you're pushing this big, long, sharp thing very hard up into the heart. When you're lucky enough to pop through, sometimes this will pop all the way over to here somewhere, which is also very scary looking. It turns out the complication rates from this is very low. Also, it turns out that if you come from above, the left pulmonary artery tends to sit right over atrial tissue, and you can go through in that space. One of the things we have learned from doing this is that there's a lot of scarring around the heart in patients who've had Fontans, particularly around that extracardiac conduit. And you're actually exiting vascular space and re-entering it. Sometimes there is some distance between those two things, but rarely do we see any kind of significant hemorrhage. In fact, we have, knock on wood, yet to see that in this particular approach. One of the things I wanted to just mention is that the technology for this. It's not that we've gotten better at doing Fontan ablations. It's really not. We understand it maybe a little bit better, but the truth is the technology has substantially improved for doing these ablations. And we can create, whoops, how do you go back? There we go. Yeah. So we can actually do these maps and get literally 5,000 points, which is the limit of points you can get. And each point is tagged with a color that represents its activation timing. So when we have a patient with 5 arrhythmias, it used to be it would take us 30 or 40 minutes to get one map of an arrhythmia, and you can't map 5 arrhythmias in any reasonable amount of time like that. But with the new technology, we can generate these maps in a matter of 10 or 15 minutes. And so when they have multiple arrhythmias, we're much better at mapping them very quickly. If they switch from one to the other, we just go back to the map of that arrhythmia. And we can, ablate 4 arrhythmia substrates in 5 or 6 hours now, which is a pretty big improvement. It has a lot to do with our success rates now, which is another reason why I think it's much better to go to an ablation early. This is just an overview of the last study. I'm going to talk about long-term survival, modes of death, and predictors of mortality in patients with Fontan surgery. So basically, what is the incidence of sudden death? How much you have to worry about this? In this study of 261 patients, there were 76 deaths, of which 7 were sudden deaths. And so in this, it's not quite 5%, but it was still a significant number, something we need to worry about. This is just looking at the long-term outcomes of that study and looking at the RA, sorry, I keep doing that. The RA-RV versus total caval-pulmonary versus RA to PA. The total caval-pulmonary is lateral tunnel and external conduits. And really, I just show the slide to show that the total caval-pulmonary connection is not dramatically better than the other two in terms of long-term outcomes. This is freedom from sudden death after the Fontan operation out 30 years. You can see that it's 94% freedom from sudden death. So not too bad, but still a significant consideration in this population. And then in that study, 14 patients had ICDs placed, all for secondary prevention. Those were survivors of sudden death. And so in this, they were survivors of sudden death or induced ventricular fibrillation, or VT, at EP study. In this study, none of these patients had an appropriate shock, but there was a significant incidence of inappropriate shocks. I bring that up because it is not trivial to put these in. It does prevent sudden death. It's a pretty good way of preventing sudden death. It's, probably 99% effective in preventing sudden death. But 20% of patients get an inappropriate shock, and that can be devastating. Patients who get inappropriate shocks, if they're not prepared for it or they're not, well-versed in handling these kinds of stresses, and if you think about it, the inappropriate shocks usually come out of the blue. They might be with some mild exercise or not, and they hurt a lot. And once you've had one or two, or I had one patient who had 56 inappropriate shocks due to a lead failure, once that's happened to you, it's hard to have this thing inside of you and lead a normal life. It's hard not to think about that happening again. And if there was no warning, no predictors, nothing you can avoid, nothing you can do to control that aspect of your life, it can be devastating. So it is not trivial to put these in. Having said that, the technology is getting much better. We can now put these in with a subcutaneous technique that avoids intravascular hardware, so those are perfect for our Fontan patients. I just have a few slides about creative ways to put ICDs in. Here you can see the ICD coil is in the coronary sinus. This is a classic Fontan, so RA to PA connection, so there's access to coronary sinus. The ventricular pace sense lead is also in the coronary sinus. And you can see this is an ICD there. This is another patient. This is their epicardial pacemaker, for some reason, is right at the apex of their heart. But they were able to get a successful subcutaneous ICD implant that was tested and did not destroy the pacemaker with testing of the defibrillator. These pacemakers are actually fairly resilient to that. So in this patient who's a Fontan with a pacemaker, he was able to get a subcutaneous ICD. This is a small child who got his coil implanted around the heart. That looks a lot like Iron Man to me. And then these are just the articles that I am quoting, or that I've talked about. I think they're actually very good, recent, long-term outcome articles for Fontan, and are I think, some of the more informative things, particularly when comparing old-style Fontans or the lateral tunnel and extracardiac. I think those two are actually, I know Brian favors the extracardiac, but I think there's some consideration for the lateral tunnel, and the long-term outcomes are not that different, and I think the jury is still out on that one. Thank you very much. I tried very hard to keep in time.